Marilyn is a forensic accountant and a senior policy fellow at the National Academy for State Health Policy. She narrowed her focus to healthcare financial management when she was the controller for the national health insurance carrier and the CFO for a regional TPA, and she's had several health management positions within the state of Montana. She took the helm of the Montana Employee Benefits Plan in 2014, and she moved that from projected reserves of negative $9 million to a positive $112 million in less than 3 years by moving some of the healthcare plan work by using data and forensic accounting. So she's really done a lot disrupting the status quo, looking at reference-based pricing, and has been paving the way in a huge part of the transparency work. With that, I will give you Her Majesty, Marilyn Bartlett. Oh, I've messed it up. That big green button.
Maybe I need to pull this down. Thank you so much. Thank you for the nice introduction. And thank you, Gloria and team, for including me. This is wonderful. What a great session. Wow. So I'm going to talk about the NASHP hospital cost tool. And this evolved from work I had started in Montana when I negotiated with the hospitals. And they told me that they lost so much on Medicare, they couldn't move to a multiple of Medicare, there was cost shifting, et cetera. I needed to know for myself as a CPA, is that true, is it not true? So I dug into the Medicare cost reports and figured out what was true and what wasn't. If a hospital would say we're losing 40% on Medicaid, I needed to look at it. So in this particular hospital, I saw they were losing 22% on Medicaid, but it was 9% of their payer mix. That's a different story. So I am a data nerd, and NASHP, Maureen is here, who leads our team, decided that maybe we could look at this. So we developed the NASHP hospital cost tool, and we use the Medicare cost reports and link it to the HCRIS database. And our reports are hospital specific. We now have 11 years worth of data, which you'll see some of the output. It was developed by the National Academy for State Health Policy with the Baker Institute of Public Policy and Rice University in Texas. And Mathematica supports our online tool, and this is supported by Arnold Ventures. So we have multiple years, multiple financial metrics. This year we added some labor metrics, as that was a discussion for states. It's an online interactive dashboard, but you can download the Excel file where you can work with the data yourself. And then we have the actual calculator online that you can input data from a Medicare cost report to calculate. So I took a look at Indiana compared to the national metrics, and this is net patient revenue per adjusted patient discharge. And your median net patient revenue per adjusted discharge is right in line. But your costs are a little bit lower. So what does that end up? That ends up profit for the hospitals. So your costs are running lower than the national average, and this is per adjusted discharge. So then we look at operating margin. When we calculate operating margin, we're looking at just the expenses that are required for the hospital patient care and depreciation, everything else that goes with that. So we take out any expenses for affiliates, unless it was a lab service, et cetera. So what we're taking a look at is the result is that the national median shows you on the purple line compared to Indiana's. This is operating margin. So for hospital operations, Indiana exceeds the national by quite a bit. Then we took a look at by bed size. Is there some fluctuation going there? And pretty consistent. The median operating margin by bed size, Indiana's running higher than the national. Now we take a look at net profit margin. This is taking all the expenses that the hospital puts in their Medicare cost report. So it's going to include, as you can see, the impact in 2021 and 2022. It's including the impact of unrealized losses in the stock market. So 2021 was a great year. So accounting rules require you to mark your asset to the value on the date of the balance sheet. So if the value of your stock was way up, you had to record it at that, and you record an unrealized gain for net income. But then we saw the market plummet in 2022. There were some losses through their investments in private equity, their investments in hedge funds, their investments in mutual funds, and in the stock market, and you saw that net income drop. So I caution you, when you see information put out by opponents, you're going to see references to net income and how poorly the hospitals are doing. And that may or may not be true. I just urge you to look deeper into these unrealized losses. The other thing that we're starting to see hit here is that some of the health systems started buying a lot of different businesses, buying a lot of different assets. Well, that same accounting rule holds true. It says that you have to write down any of your assets to the market value. So if you bought an asset for $10 million, a particular business maybe, but the value's not there, you no longer can amortize that loss over a period of time. You got to take it that year. And we'll show you an example of that later. So there are a lot of unrealized cash items coming in and out that you have to look at when you see that published. So again, we looked at where is Indiana coming on net profit margin. And I think this speaks for itself when you look at the 101 to 250 and 251 and over bed size. Indiana net profit margins are pretty high. This is 2022. So now we're looking, we thought, for states, they really wanted to know what was going on with direct patient care. So what we carved out was direct patient care for the hospital care. So this is your nurses, your people on the floor, your lab techs, people that are working on direct patient care. It does not include the physician services that are billed separately for the physician direct patient services, but it will include the physicians that are 24/7 in the emergency room, 24/7 in ICU, the hospitalists, it will include that. So we're looking at direct patient care cost as a percent of hospital expenses. And it's interesting, you do see that uptick. And this is going to include contracted as well as hospital staff and fully loaded with the benefits for hospital staff. So it is an uptick, but I think it's got to be put in the context of how serious is this. We take a look at Indiana and it's lower. Now, recently, there was a report published that said 60% of hospital expenses are in salaries. And I think you need to find a little more information about that. What expenses? Did they load in any expenses for the physicians or not? But just the direct patient care, which has been hitting the news in contracted nursing, travel nursing, additional pay, you kind of got to dissect it a little bit deeper. There are some increases there, but how significant are they? So we took a look at comparing this, and these charts can get a little confusing, I realize, but the one on the left, we looked at the contracted labor FTEs. So we did FTEs, and we compared it, and you can see that Indiana was a little bit lower. So this is of the FTEs, like around 4%. National 5% of the FTEs in direct patient care were contracted. Now on the right, we show that comparison in the salaries. And this is by the state medians. And we look at the hourly rate. And what I always find interesting is I look at that trend of the hospital staff. And it, in many states, is fairly flat and even not much of an increase. So were we paying direct patient care staff an appropriate salary over time? Maybe we were, maybe we weren't, but it's a question to ask. And then you see the increase in the hourly rates that came when the market switched. So the tool allows you to look at a lot of state metrics if you're looking to manage that. But then you can drill down and you can look at Beulah Hospital. So I picked Parkview Hospital, Fort Wayne, only because I've done Ascension, Franciscan. I thought, IU Health, I'm going to let somebody else get the hammer this time. So I took a look. Now, one thing we did in the tool this year was we split the hospital expenses. Now, this is the total expenses reported by the hospital in the Medicare cost reports. So we split it into these categories. The green, the bottom line, is what they record as capital expenses. So that's not going to be cash flow. That's going to be your depreciation, insurance, lease expenses, interest. So to maintain your bricks and mortar, basically. Then the pink line on this one is direct patient care cost. So you can see that that is going. You can see that that does go up. They're following the trend of Indiana. You can see that that goes up after the COVID time. The interesting one here is we look at the other hospital operating costs that went up. Now, this is going to be supplies. This is going to be equipment that can be expensed. It's going to be all the other hospital operating costs. And there's a sharp increase there and a continued increase, and we need to look at that. So when we dig down in some of the data, we're able to see, is it your GPO agreements you have for purchasing supplies? We've seen some really increases in that. And you need to look at, are you giving it to me net? Are you giving it to me on what the cost was, but what your rebates or can't use the kickback word, but what the rebates or the money given back to you was. And so we take a look at that. The yellow line is labor costs other than hospital direct patient care. What this is not going to include the physicians, again, that are billed separately, but this is going to include overhead, and that's housekeeping, dietary, all the other services that are needed to keep the hospital going, contracted and hospital staff. It's going to include executives, executive and management, and it's going to include home office allocated salaries. So any home office allocation over. So these are questions that you'd want to take a look at. What went up and why? And then finally, we have the dark purple line, which is additional expenses that are not related to hospital patient care. Now, for hospitals, this could be the unrealized losses. They're going to put that on their books. It could be research expenses, because we aren't looking at research income. It's going to look at a lot of those. So really what has happened there. But then we thought, let's look at that information allocation. So this is when we put it on the chart for 100%. The expenses went from $499 million in 2011 to $1.8 billion in 2022. So we look at how was that allocated? Now, we've already talked about the bottom line, which is direct patient care. That's down there, around 10 or 12%, I believe. We already talked about the yellow bar. That is the labor expense, not the direct patient care labor expense, the capital items, and then we talked about the blue bar, which are those other hospital operating costs, and they're worth looking into. And then finally, the purple are those expenses not related. So you need to kind of look at the trend. Yes, expenses went up, but did they shift in where they were spending the money? Did it go to direct patient care? Doesn't look like it. This is a bar chart. You can run this for any year. We ran this for 2022, and they stopped using the contracted labor at the end of 2020, and they have increased their salaries, as you can, or the payment. It could be FTEs or salaries, so you can take a look at what's happened to direct patient care labor. Again, this is contracted and staff. Now we dig in a little bit further. We're using this chart to look at the FTEs, and what Parkview did, you can see the blue line. They had contracted labor for direct patient care, but they stopped that. And instead, you can see they've increased the FTEs in the green bar. Then on the right, same as the other chart was we showed for the state, we're taking a look at what did the rates do. Again, the rates stopped with the blue bar because they stopped using contracted. And then you can see the rate change for their hospital staff. And this sounds like a lot of data, but it's good to get into this when you start hearing the conversation of, well, we're just getting killed by our direct patient care staffing labor. Maybe they are, maybe not, but this helps you frame up some questions when you are working with this. Now, this particular one we looked at, you're going to see a lot of this in the news. And there was a recent article I saw published here in Indiana where you have to take a look at what's going on with adjusted discharges. So if you look at the chart on the left, one could say, well, our direct patient care costs have decreased per discharge. But you got to look what's going on with discharges. In most cases, it's because discharges went up. That denominator went up, and so it's lowering that. I'm boring everyone. Aren't accountants just the most boring people in the world? So I throw that out as something to think about. You've got to really look at these metrics and how they're measured because you can make them tell pretty much any story you want. Now, this I love. When I was negotiating in Montana, we moved all the hospitals to a multiple of Medicare. Now, this is for Parkview. This shows you what their total charges are, the yellow line, steadily going up. That's their charge masters, going up, 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 up. And then we look at their actual hospital operating costs. So my argument on this was, why do I want to keep paying you some secret discount off an uncontrollable charge master? I'm not going to do that anymore. I want to pay you cost plus. I'm an accountant. That's what we do. And I use this as an argument. And as Chris pointed out, Medicare rates are meant to come close to break even. So if I can pay you 200% of Medicare, I'm paying you pretty much double your costs. But then it's transparent. I knew what Medicare paid. I could always check it. And every contract was different. I really do not like discount off charge master, obviously, if that wasn't apparent. So I really urge you to take a look at these things, and especially when you're talking to your provider network. So we do break-even analysis, and we've worked with Rand, we've worked with Chris, has helped us out with this quite a bit. So what we take a look at is commercial break-even. How much the hospital needs to be reimbursed by commercial payers to cover your own patient hospital costs, if there are any losses from other payers, cover charity care, cover bad debt, cover uninsured, and all the Medicare disallowed costs. So this is going to include definitely the research, some of the affiliate expenses that they put on the books. And then we bring in other income and expense. So really, what would a commercial payer have to pay as a multiple of Medicare for you, hospital, to break even? And then we're able to compare it to the RAND price. Chris works with us to make sure we have inpatient, outpatient, because we do not do professional. So you can see here, Indiana is running higher than the national median. Now, we've seen it come as an increase this year, and that's because of the unrealized losses on investments that are there. So keep that in mind. Yes, operating expenses may have gone up, and we can look at the other data and see that. But the main reason that the break-even came up is due to the market. So it'll be interesting to see what happens in 2023. So this was interesting to me. Parkview Hospital, Fort Wayne, they're running pretty high as a break-even. And so I dug into the detail to see why. And they're including a lot in their other expenses for some of their affiliates and some of their subsidiaries. There was $239 million of expense that they labeled as a physician group subsidy. And that was up quite a bit from 71 million in 2015. So you have to kind of look at what's going on there. And then they also had the unrealized losses. So we compare on the chart the break even that we have calculated. This is 2022 against RAND 4.0, and we show as a bar chart so you can see that. And we share all the data with Sage, and Sage brings it into a format that you can compare much more. Now we're looking at health systems because the hospitals many times are just part of a huge, huge system. As Chris talked about consolidation, mergers, states are definitely looking at that. So I did an organizational chart for Parkview. It took a long time. And the blue are not-for-profit hospitals. And as you can see, my little red circle is the one I just highlighted. So I just looked at one little piece of this group. The green are other not-for-profit entities that they own. The orange color are for-profit entities that they own. Then they are in the yellow in a lot of joint ventures and affiliates. Many times I find these joint ventures and affiliates are really good referral channels for the hospitals, so you kind of want to dig into that. And then disregarded entities. Oh, this is an accounting term. A disregarded entity is a IRS term, and these are LLCs. They're single owners. So these gray bars are owned by the top parent company, and they have a single ownership and are pretty much governed by the parent. But the interesting thing on a disregarded entity is they take on the tax status of the one that owns them. So these items down here that are retail companies and that are real estate and holding companies, they're treated as non-taxable entities. So I think, that's accounting. I'm going to ask for CPE credit for this. So it brings up the issue. A colleague had just texted me that and asked a question, and it brings up the issue, is there cost shifting going on here? Are hospital prices increased because they're covering particular losses or investments in these other entities? So digging a little bit into that, it has proven to be challenging, but we're working on it with NASHP. So when I look at the system as a whole, and this is from their audited financial statements, I take a look at their operating profit margin and their net profit margin. And you can see that operating profit margin going down. Now, this is all those entities together. But you look at the orange line, and that big dip was mainly 205 million unrealized losses in 2022. So we're starting to look at these huge systems and what's going on with the money through those. So when I showed you that one comment that they did a physician subsidy, it was, I should have shown it on the slide, there was another entity that was that physician organization that the one hospital gave 235 million subsidy to. So you see the money going back and forth between them. So we were fortunate through NASHP to get to work with Gloria and with Representative Shabley this year. And one of the things that we did was take a look at systems. How are the systems doing? When they would come to the legislature and Representative Shabley and Gloria were just hammering away at their bills, they would say, you know, we're going broke. We have lost so much. And they talk about how much their days cash on hand has dropped. And that may be true, but realize that the cash on hand is the total of these bars. And when you have unrealized losses, your investments drop and your cash on hand drops. So you got to kind of dig into that. I'm getting way too into the detail. So what I looked at, this was Parkview Health financials, and the 205 million unrealized loss in December 2022, they've kind of held their own from that. But the thing that's interesting about these charts is it's very rare for me to find a health system that's not in better financial investment position than they were before COVID. We look at Ascension. Yes, Ascension's rather interesting. There was quite an influx of federal funding for the COVID-related through June of 2021. They had a $5 billion unrealized loss on their investments in 2022. 2023, they had another $2.6 billion unrealized loss, and they also had a mandatory write-down for impairment that reduced their investment balances too. Well, this was interesting. You got to read the footnotes a little bit more because it could be that it was a write-down of a building or a write-down of an investment, but this one was a write-down of an investment that didn't hold its value. And that's when you get more into the hedge funds, private equity, those types of areas. Franciscan Alliance, they had a $500 million unrealized loss, really dropped, but they've regained some of it, and this is where they stand at December 2023. IU Health, great rebound there. 1.3 billion unrealized loss, but they're right back up there and definitely higher than pre-COVID. Community Health Network, I could only get their financial statements through December 2022. This shows their position and their unrealized loss. Then finally, we take a look at the operating profit per adjusted patient discharge. This goes back to our hospital cost tool. What profit, now this is the profit, not the cost or the revenue, what profit are they making per discharge? And it lines up this up by health system. And I think that this is just kind of helpful information for you. If you're negotiating with the hospital, if you're doing a direct contract, it's working out for us at NASHP to be able to work with state regulators, with legislators, when we were able to work with Representative Shabley and talk about what are the true financials to kind of counter some of the messaging points. And we're not here to, it doesn't sound like it, but I'm not here to do a gotcha. I'm here to say that we need hospitals, but we need prices, and we need to be able to afford the care. So digging in and finding where some of this money is going is critical to our whole effort here for states and for employers. So I thank you. That's the hospital cost tool.